Today, I'd like to provide a better understanding of inpatient rehab pre-authorization requests. So I'm going to cover three main topics. First, why do we need pre-authorizations? Second, why a rehab request may get denied. And third, the way therapist notes may sabotage an inpatient rehab approval. If you don't know who I am, my name is Philip McGee. I'm a physical therapist who works full-time in utilization review, and I have reviewed thousands of inpatient rehab authorization requests over the past year. Now, why do we need pre-authorizations? I like to give the analogy of a referee or an umpire, and actually the very first job that I ever had was being a soccer referee. Now, referees, they're oftentimes not liked very well. Very few times does someone go to a sporting event and go, wow, that referee did an amazing job, or an umpire is applauded for how well they can call balls or strikes. Now, the purpose of a referee or an umpire is to enforce the rules. Now, the same thing happens with pre-authorizations. We would like to believe that clinicians that they know the rules and that they can follow the rules, but unfortunately we know that there has been fraud and that there has been an overutilization of services, so there are pre-authorizations that are in place. So what are the rules? Well, if we look at Medicare Benefit Policy Manual Chapter 1, we know that under Section 110, I'll scroll down, there is Inpatient Rehab Facility, or IRF, services. If I click on that, it will take me to Section 110, and it talks about the inpatient rehab services. And if we go to 110.2, which right now it's on page 34, it talks about the 5 musts of an inpatient rehab admission. Now, when it comes to this, some things are more objective and other parts are a little bit more subjective. Just like the example I gave of a referee or umpire, there are some referees that are very strict to the rules and others that are more lenient with the rules. And when you have someone who is making a decision for a pre-authorization, they may be more strict or they may be a little bit more lenient. But these are the 5 musts. First, the patient must require at least 2 services, and one of those services has to be either a physical therapist or occupational therapist. The second is that they need 15 hours of therapy per week, or typically what is done is 3 hours, 5 days a week. The third is that there is a reasonable expectation that they're going to have an improvement. The fourth is that there must be a physician who oversees the member 3 days out of the week. And then the fifth is that there needs to be an interdisciplinary team approach for providing the rehabilitation. So those are the 5 musts, and those are the reasons why an inpatient rehab authorization request will get denied. As a physical therapist, the main thing that had been reinforced to me was number 2, that they need to be able to tolerate 15 hours of therapy per week. But I would say the most common reason for the denial for inpatient rehab is going to be whether they need physician oversight 3 days per week. Now, I will say that you have, just like referees in sports, there are some that are more strict than others, and you have to take that into consideration, which is why I talked about in another video how to appeal a denial. Another thing that I'd like to point out is at the beginning of Section 110 on page 31, it says that Conversely, the IRF benefit is not appropriate for patients who have completed their full course of treatment in the referring hospital but do not require intensive rehabilitation. Medicare benefits are available for such patients in a less intensive setting. Another thing to consider out of those 5 musts are that if care can be provided at a less intensive setting or a lower level of care, such as skilled nursing or home health, then it's not viewed as medically necessary. The third topic I wanted to discuss was how a therapist's notes may sabotage an inpatient rehab approval. And I'll speak from experience that there were many times as a therapist that I was working in the ICU and I wanted to provide aggressive therapy. So I would have people walk hundreds of feet thinking that I was helping them to show progress. Actually, I was sabotaging their ability to go to inpatient rehab because they looked like they were doing too well. And what the purpose of me talking about this is not to shame anyone, but to help provide some insights because I think a lot of therapists, they just focus on trying to provide as much therapy as they can, and they're not really thinking about how it may look like they could handle a lower level of care, such as skilled nursing or home health. So, one of the things that I oftentimes see is a discharge recommendation of inpatient rehab versus SNF or versus home health. And the thing to consider there is that, as I said, if this can be provided in a less intensive setting, then it's not medically necessary to have intensive therapy. And so I would recommend avoiding the statement inpatient rehab versus another setting. A common mistake is that therapists will provide treatment at a modified position, say for instance, the bed being elevated or the height of the hospital bed being elevated, and just documenting how well the member did in those modified positions and making it look like they don't require as much assistance as they actually do need if they were in a flat position in the bed or they were in a standard height chair. So one thing to consider is this going to be like the member's true living situation? There have also been times when the therapist will discharge the patient prior to admitting to inpatient rehab and stating that they no longer have skilled needs. And unfortunately, if there aren't two disciplines that are seeing the member, it's going to make it much more difficult to get the member approved for inpatient rehab because that's one of the requirements. They need at least two disciplines, and one of those disciplines needs to be either PT or either OT. An issue I've seen come up includes having the member decline therapy services, oftentimes multiple times during their hospitalization. And I would say it's very difficult to show that the member is going to handle 15 hours of therapy per week when they're frequently declining therapy. Another issue is having someone just perform bed exercises or just perform bed mobility. Now, if they're not safe to perform transfers, then there's no point in trying to do something that's going to harm the member, but it makes it difficult to show that someone can tolerate 3 hours of therapy if all that they're doing are bed exercises or only sitting on the side of the bed and not really performing any other tasks. I hope this video has provided a better understanding of why there are pre-authorizations for inpatient rehab, the criteria for inpatient rehab, and if you're a therapist, knowing the things to do or not to do to help provide the best chance of getting an approval. If you found this video helpful, please like and subscribe, If you are interested in a career in utilization review, I do have a course online that is a step-by-step process on how to get into utilization review. It's called Nonclinical Utilization Review. The link will be down in the description. And I also provide resume reviews and practice interviews. I also have a free ebook on how to write non-clinical resumes that get interviews. Thank you so much for watching, and I hope to see you in the next video.